Okay, let's get started. As a time check, it's 11 a.m. in Singapore on Tuesday, 27th April 2021. On behalf of the Sing Health Duke-NUS Global Health Institute, I'm delighted to welcome all of you. And I know that most of you are from Singapore, but we have many from beyond our borders. So it's great to have you all in this kind of virtual room. I'm Amina Mahmood, Deputy Director of the Institute, and this talk today is part of our monthly Global Health Seminar series. In these sessions, we draw on our faculty as well as guest speakers to present topics of global importance and really engage with our community in Singapore and, as I mentioned, beyond Singapore too, which is really what our mandate is. Today, we address a very central issue in global health, the impact and implications of a rapidly aging society. The topic of today is caring for persons with dementia towards a sustainable community-based dementia care system. Presenting this topic is Dr. Angelique Chan, who is the inaugural Executive Director of the Center for Aging Research and Education at Duke-NUS. She is also our SDGHI faculty and holds joint appointments as an Associate Professor in the Signature Program in Health Services and Systems Research at Duke-NUS Medical School, as well as the Department of Sociology at NUS. Dr. Chan's work is focused on issues related to aging, including disability transitions, mortality, and the effects of social support on health, caregiver burden, and the use of long-term care services. She has published widely in leading international journals, including the Journal of American Geriatric Society, the Journal of Aging and Health, and the Journal of Gerontology Series B, Social Sciences. She's written book chapters. She's co-edited anthologies. So, we could go on. But really, what I also want to mention here, as it's always relevant to us for her regional work, she collaborates with researchers from Japan and the US, focusing on caregiving, work and retirement, and disability transitions. She has consulted for various local Singapore entities, as well as international bodies such as UNESCAP, the World Bank, and the Asian Development Bank. So Angie, we're delighted to have you with us today, and thank you for your time. And just before I hand over to you, a few housekeeping notes to the audience. Please keep yourselves on mute during the presentation. The webinar is being recorded and will be available on our website later on. And you can ask questions at any time by posting your questions in the chat box, but it'll be addressed at the end after the presentation. So welcome all of you. Welcome, Angie. Thank you, and over to you.
Thank you very much, Amina. It's a real pleasure to be here today, and thank you to the Sing Health Global Health Institute for the invitation. I'm talking about a topic that's very close to my heart, and it's a project that we recently completed at the Duke-NUS Medical School relating to empowering caregivers of persons with dementia to care better for their loved ones. This is a project that was done with, it was an interagency collaboration. At CARE, several members, research fellows helped out. And at the Sao Foundation, many thanks to Marianne Sao, who actually had her team in an area of Singapore implement the program. And thanks also to the grantor for their support, the Singapore Ministry of Health. We were supported under a National Innovation Challenge grant, which is given out by the Singapore Ministry of Health to encourage research around innovative approaches to the challenges of population aging, and dementia care is one of them. So as I wrote in my abstract for this talk, a new case of dementia is reported every 3 seconds. And the WHO actually launched their Global Action Plan for Dementia 2017 to 2025. I think it's important for us to remember in this region that 60% of people with dementia live in low and middle income countries, and most of the new cases, about 2/3 of them, are expected to occur in these countries. Now, if you look at the WHO Global Action Plan on the public health response to dementia, it includes a variety of areas of focus. One is, to increase prioritization in public health policies and programs regarding dementia, and also to increase public awareness. Secondly, to reduce risk of dementia through clinical interventions and possibly community level interventions. It encourages diagnosis, treatment, and care innovation for dementia. And relevant to today, the plan also encourages new ways to look at support for dementia carers, strengthening information systems for dementia, so referral systems, multidisciplinary approaches for care for dementia, and also research and innovation. So today's talk is really going to be focusing on how can we support carers of persons with dementia, and what are innovative ways to do that. And importantly, how an attempt to do that in an Asian country like Singapore worked out, to put it simply, and what are some of the issues that need to be taken into account in Asian settings, which have particular cultural and social contexts. And so I'm going to be discussing that, and it's going to be from a research and innovation perspective. So just a little bit of background. I'm sure a lot of you who are on the webinar today in the audience know this, but I'll just briefly mention that Singapore is aging rapidly, and then by 2030, almost a quarter of the population will be above the age of 65. And currently about 10% of older Singaporeans above the age of 60 have dementia. And by 2030, it's projected that there will be about 90,000 Singaporeans with dementia. At present, we know really very little about the needs of community dwelling persons with dementia and their caregivers. Because if you think about it, persons with dementia and their caregivers often present in tertiary care settings. So they present in hospital settings when things, circumstances have gotten quite bad. The person with dementia may have serious health issues, and caregivers are at a loss, and therefore they present in the clinic. But what is happening in the community? How are carers dealing with that? There's not been a lot of systematic research looking at the needs of caregivers in the community, particularly from an interdisciplinary perspective. And there's not been a lot of research on how to develop or manage dementia care systems within communities. And for us in Asia, it's a very, very new territory. So what we tried to do in this research study, and we call it the cognition study for short, it was a 3-year research project. And the goal here may sound simple, but it was to, the first goal was to identify unmet needs of cognitively impaired persons and their caregivers. So we can't think of programs until we know what people need. And a lot of times programs are developed without doing this step. And so we wanted to know first of all, what are the levels of cognitive impairment in communities? Given that we're going to have such large numbers of persons with dementia in Singapore at large, what does it look like in the community? And to what extent are there behavioral issues among persons with dementia in the community? Because often behavioral issues are instigator of caregiver burden, and often a trigger for carers to put their loved one in an institution. We wanted to know the extent to which caregiver burden existed, and to look at issues around quality of life for carers. This was done in an interdisciplinary setting. On the team, we had sociologists, psychologists, economists, clinicians, nurses, social workers, and public policy researchers. we wanted to understand the issues around implementation, and we also wanted to look at cost effectiveness. And the final goal was to develop a blueprint for a dementia care system in the community. Now, these were our hard outcome measures for this 3-year study. We, at baseline, measured MMSE, which is a scale to measure level of cognition. Their scores, 20 to 24 suggest mild dementia, 13 to 19 suggests moderate dementia, and 12 or less suggests severe dementia. And this is a validated scale for Singapore. We also included a revised memory and behavioral problems checklist, which is a widely used scale to assess the presence of behavioral problems in dementia patients and the extent to which caregiver distress is associated with these problems. So we asked caregivers how different behaviors of the person with dementia, for example, wandering, kicking, biting, shouting, sleeplessness, affected the caregiver. And higher scores indicated behavioral issues were more frequent and more upsetting for caregivers. And finally, we used an assessment of need for elderly, which assesses need, particularly for elderly who have mental health disorders. And these needs were in 24 areas of life: health needs, social needs, and psychological needs. And the responses was, there's no need. You could say, there's a need, but it's met. There's an unmet need, so I really need help with depression, for example. Or the older person may say, I don't know. The last 2 outcome measures revolved around the Zarit burden interview, which is a measure of caregiver burden. So caregivers were asked questions on a scale that were coded 21 to 40, suggesting mild or moderate burden, 41 to 60 suggesting moderate to severe, and 61 to 88 suggesting severe burden. And again, this is a scale that's widely used to assess caregiver burden internationally. And in terms of quality of life, we use the Euro Qual 5D, which is a self-report description over 5 domains, including mobility, self-care, usual activities, pain/discomfort, and anxiety and depression. Participants were also asked to rate themselves on a visual analog scale that ranged from 0 to 100, where 0 was the worst imaginable health state and 100 was the best imaginable health state. So just to recap, the study had several components. The first one was the community needs assessment. So in order to develop programs, you need to understand needs. And we wanted to understand what were the unmet needs of cognitively impaired persons and their caregivers in Whampoa, which is an area in Singapore. And in order to be eligible for the study, an individual had to be a Singapore citizen or permanent resident, age 60 and over. The person needed to have screened positive for cognitive impairment. That is, we use the AD8 plus 2 MMSE score. You have to have less than 8. The person needed to have a primary caregiver, age 21 or older, and lived in the area. In addition to this quantitative needs assessment, it was a mixed method survey. And so we also conducted qualitative interviews with mildly cognitively impaired persons, their caregivers, and community members. Community members meaning the police, the civil defense, general practitioners, individuals who were providing services, other services in the community, other long-term care services. In phase 2 of the project, we actually did an evaluation of the dementia care system pilot that Sao Foundation ran. And the way we did that was both quantitatively and qualitatively. So in terms of the quantitative assessment, we did a baseline interview and a follow-up after 6 months. In-depth interviews were done at baseline. There was a side project, which was a cognitive therapy program, which I can talk about later if anyone's interested. And then we did a cost effectiveness analysis. So let me just talk you through what the intervention consisted of. And I think this is important when we think about developing intervention systems for dementia, for caregivers specifically in Asia, because really focusing on the different elements of the system and getting that in place and understanding what the role of each member in the team does will lead, to a higher probability of success. So the first thing that the Sao Foundation wanted to do was to really model the service after a person-centered medical home concept. And they wanted to provide primary care, behavioral management, psychosocial support, and social engagement, both for the person with dementia and the caregiver. It was very much an integrated program, an interdisciplinary team. So there was a primary care physician, a social worker, a nurse, a care manager, a dementia care program assistant, which ended up being one of the most crucial persons, and an assistant care manager. And so the team members were trained to provide care and support to the person with dementia, family members, and caregivers. So it was really looking at the family system and family dynamic as well, not just looking at the person with dementia or the caregiver in isolation. And I think that is an important element for success. Another goal of the program was to create a relationship or empanel the care recipient with the primary care physician for ongoing care, someone who could keep track of the person with dementia and notice changes, subtle changes when they occurred. And the intervention itself was meant to be short-term, 6 months, and to really focus on building capacity of the care recipient, who is the person with dementia, and the family, build their capacity for self-care by helping them arrange appropriate services and providing education about the disease itself and ways to manage it. So it was a very holistic approach. It was care through partnership with family members, caregivers, service providers, and community members in order to manage the care and well-being of the family. So briefly, these are the roles of the medical doctors. The primary care doctor, assess, treats, develops the care plan, monitors health, maintains records, and liaises with other doctors who may be and specialists who may be providing care for the person with dementia. The nurse goes in and does a comprehensive needs assessment and creates a nursing medical plan, and is basically the lead in planning for caregiver education and person with dementia therapy. Now, the social worker in this case, the care manager, does a psychosocial assessment of the person with dementia and develops a plan to support caregivers and to help caregivers coordinate care for the person with dementia. Remember that the whole goal of the program is to support caregivers primarily, to support them supporting the person with dementia. And the better the program could support caregivers, the lower the likelihood that families would move their loved one into an institution. And so lots of coordination of referrals, home visits, counseling, even legal and financial planning. The assistant care manager provided support, and the dementia care program assistant was developing activities to engage the person with dementia. Often persons with dementia are left in the home all day They are cared for in terms of being watched over, but there's very little for them to do, which can lead to behavioral issues and increased rapidity of memory decline. The dementia care program assistant also helped with caregiver education, helped to counsel with caregiver dynamics if there were several people caring for the person with dementia, which is often the case in Asian families, and stress. The dementia care program assistant was a coordinator between the nurse and the care manager, sort of a spokesperson for clients and family. And the program assistant also logged diary observations for the team. So these are the steps. There's referral and screening. There's needs assessment at home. So the dementia care service actually goes to the home of the person with dementia and looks at the home, talks with the caregiver, look what the environment is like. This is followed by the intervention, which is a mixture of coordinated home visits, weekly team reviews, telephone consultations with the family, and follow-up, which is a review of the care plan for the person with dementia and the caregiver at 3 and 6 months. And then there's a transition to discharge. When the family is assessed to be stable and the caregiver can manage care independently, then there's a move to discharge this family from the system. Now, these maps may not make a lot of sense to those of you who are international, but the idea behind them is if you take a community where there's a lot of older persons residing, it's a good idea to map out the services that exist in that community. So very briefly, the purple markers are for general practitioners. So there's 7 of them in Whampoa. In terms of hospitals, ranging from very large hospitals to smaller ones, there's 6 of them. Respite care, there's 5 services. There's 2 senior activity services, 1 24-hour family clinic, and 1 family service center. So this is what the dementia care service team had to work with in terms of local referrals they could make to support the family in caring for the person with dementia. Now, what were the results from our study? Going back to the needs assessment study, which formed the base of the work, we found 3,589 people aged 60 and over in Whampoa. That was about 70% of the entire list we were given by the Ministry of Health. Out of those, about 323 were diagnosed to have scores less than 8. So we're diagnosed to have dementia, and that's a little under 10%. So it's in line with what we expected. And then in terms of people who agreed to be in the study, there were 266. This was not a randomized controlled trial, and it indeed is one of the limitations of the study. The providers, the South Foundation, did not feel it was appropriate to do a randomized controlled trial in this sense because they could not deny service to individuals that were found to be in need. So we compromised and we agreed that we would look at individuals who and their caregivers who agreed to be in the study. So 266 dyads completed the needs questionnaires. And let's look at this community. Let's look at we lost a couple, I think, due to missing data. But in this community, out of the sample that we got, about 32% are in the severe dementia category, 35% have moderate dementia, and 18% have mild dementia. So in the community, there's actually a relatively high proportion, about 67% of individuals who are in the moderate to severe dementia stage. And that's actually worrying because these are individuals that may or may not yet have presented to the healthcare system. And identifying ways to maintain and support them is crucial to prevent negative outcomes. And so then we said, okay, so who are these people with dementia? So these 266 people, well, they're on average 81 years old. They tend to be more female and they tend to be more Chinese. They tend to be married and they tend not to have any formal education. They're not working, although 5% of them are. And we haven't looked at this group, but it's an interesting group to look at. In terms of socioeconomic status, in Singapore, we can actually use housing type as a pretty good proxy. The majority of them are in the three-room housing development board flat. And the majority live with family members, although again, there's that 5% that live alone. This was a quick graph, looking at the data that we want to do further analysis, but just to show you that if you look at people who are, in the moderate dementia category, that they tend to be older, female, and non-Chinese actually. And the people who are in who are less likely to have moderate dementia are those who have completed tertiary education, are working. They tend to have a higher MMSE score. Let's move to the caregivers. Who are they in the community? Well, they're on average around 63. They're women. They are Chinese. They tend to be married. They tend to have some education, secondary education. They tend not to be working, although almost half of them are working, which raises issues around caregiver hours. In terms of financial resources, they report adequate or more than adequate in 52% of the cases. And the caregivers, on average, are children. So now let's look at the needs of persons with dementia. There were 24 items, and this is just a sampling of the questions. Does the person have an appropriate place to live? How is the person's physical health? Are there problems with mood and anxiety? Does the person have a close emotional, physical relationship? And again, the response categories were this need is met, it's unmet, or there is no need. So out of the 24, these are the top 10 needs reported by persons with dementia. Now it's 135 here out of 266 because these were the people with mild cognitive impairment. And there's literature to show that you can indeed ask these questions if a person is only mildly impaired. So let's focus on the orange. Now, one of the things that struck me was the very low numbers or percentages of people reporting unmet needs in these various categories. I mean, the 13% here unmet need is really related to having issues around memory, which you would expect. But there's very, little unmet need in terms of being able to look after your home or being happy with your social life or managing money. And we'll get to that in a bit. Now, these are caregivers. Now, all the caregivers, the 266, were able to answer questions about unmet needs of the person with dementia. And again, unmet needs were very, very reported, very, very few people reported unmet needs. And the highest proportion related to how does the person occupy their day? And this will be very important later on. let's talk about caregiver burden and how did caregivers respond to that scale, the Zarit burden interview scale. This scale had 22 items and it had questions in it like, do you feel your relative is dependent on you? Do you feel like you don't have enough money to care for your relative? Do you feel stressed? And a person could say never, rarely, sometimes, quite frequently, or always. And if the caregiver had a score less than 24, that caregiver is at risk of depression. So these are what the scores look like in one poll for caregivers of persons with dementia. So about 30% said there was little or no burden, mild to moderate burden, 62%, moderate to severe, 8%, and very severe, 1%. So what do they feel burdened about? And these are the top 5. Feeling that the relative is dependent. So feeling, I think, a lot of responsibility, this person is dependent on me. 12% said quite frequently that they felt they don't have enough money to take care of the expenses. 9% said, nearly always or quite frequently they feel burdened taking care of their relative. 8% say they feel very stressed and worrying about the future. So these are the issues that concern caregivers. So in summary, the needs assessment showed that 68% of community dwelling persons with dementia have moderate or severe dementia. And on average, these persons are 81 years old, female, living with family, although 5% live alone, and they're uneducated. And not a lot of caregivers report unmet needs in the survey format. And although I'm a quantitative sociologist and I love surveys, I have to say in this case, the survey did not help very much. And that when it comes to doing work with families of persons with dementia, there's a need to really do qualitative interviewing or to at least do a mixed method survey. So this was very much a learning experience for us. Having said that, a higher caregiver burden is related to caregiving responsibilities, finance, work-life balance, and concerns about the future, as you saw in earlier slides. So qualitative findings, our qualitative findings were much more elaborate and detailed. These are the things that caregivers said caused them a lot of stress. The memory and behavioral problems did come up as an issue that strained communication and lowered caregiver emotional well-being. So having to repeat things when an older person argues, having to scold an older person, all of these are related to caregiver stress. Challenging behavior, nighttime activity, wandering, and violence were things that were related to increased caregiver burden. Lack of knowledge, that was a major issue that came up. So not knowing what to do, what's the next step, how are things going to progress. Negative impact on caregivers' own health and social well-being. This one person said, it's tough, spine is crooked, problem changing diapers, problem with mobility, quarreling, and stopping usual activities to provide care. And then the struggle of balancing work, finances, and other family responsibilities. Because if you think about the average caregiver age being 63, these are often people who are caught caring for the younger generation and the older generation at the same time. So in phase 2, we actually evaluate the care model. And out of the 266, we had 47 intervention and 76 control dyads. And we did a 6 to 8 month outcomes assessment. We were looking at whether the program lowered the rate of cognitive decline, reduced memory and behavioral problems, reduced caregiver stress, and was linked to a better health-related quality of life at the end. Now, this won't take me long because in actual fact, we did not find significant differences between the intervention and control groups. Now, remember, it's not a randomized control trial. However, if we look at the demographic characteristics of both groups, and you'll see that there are no significant differences in terms of their age, gender, ethnicity, marital status, education, and employment. So they all started out in our program the same in terms of these characteristics. We did find that the intervention group, which is outlined in orange, did have, and these are the screening scores. So remember, if you scored 8 and below, you could enter the program. So the intervention group, which is the orange lines, they tended to have lower scores. So they were worse off when they came in the program compared to the control group. This makes sense because people who are worse off would want a program to help them and would be more likely to enroll. And so this is a difference in differences analysis. That's what we did to counteract the fact that it wasn't a randomized control trial. And what this difference in difference analysis is yes, you do compare the control and intervention group from baseline to outcome, but you also compare what happened within each group. So within the control group, did individuals get better or worse? And within the intervention group, did people get better or worse? And in terms of cognitive scores, there was really no difference. And I put that down to the fact that in 6 months, you can't really change an individual's cognitive scores. The program also did not impact the older person's memory and behavioral issues and how it related to the caregiver stress. So we saw little change there. However, we did see that the Zarit burden interview scores, which relate to how stressed and how burdened the caregiver is, increased significantly for the control group. So the group that was not receiving the intervention, they saw over that 6-month period, their caregiver stress levels going up, and the intervention group did not. So their stress levels were somewhat controlled. Now, I don't have time, I don't think, to go into, I think I only have about 5 minutes left to go into all these qualitative findings. But what I want to show you is the idea. So if you have results, so what are the types of memory and behavioral problems reported? So not attentive, scolding, having to show them the way, not having patience. The impact of an intervention and the need for areas of intervention is in psychoeducation and the program facilitating communication between the caregiver and the person with dementia. So the caregiver ended up saying at the end of the program that, yes, we were educated about dementia and we tried to give him a routine. Now we know his needs, because we actually talked, with communicated, and we're more careful with the way we talk to him. So you can imagine that just getting this done would take a lot of time, and these service only had 6 months. So, the expectation that we would see a lot of change in 6 months is actually a pretty high expectation. But I think we should focus on some of the qualitative findings and also some of the remedial actions that the service took to help with challenging behavior. So in this case, what the service did was they referred the family to more center-based physiotherapy, music therapy, and art-based activities. And what did the carers say? A lot of different activities for her. She comes back, she feels better, she sleeps better. in this other case, the person with dementia doesn't like to talk to people, doesn't have any interaction with outsiders, but with the service person coming in, playing games, she's welcoming, she can be accepting, and her mood and behavior has improved. So I'll leave you to read all of these, but essentially helplines, more accessible medical care for the caregiver to allow greater self-care, social care and assistance with application for subsidies and financial help. Really, all of these help caregivers in caring for themselves and their families. So in conclusion, from a research perspective, and I'm sorry I keep bouncing back and forth between the practice and the research, but please ask me questions after. From a research perspective, identifying people, persons with dementia is possible, but it's hard to get families into an intervention. So in some cases, the study needed to recruit from existing clinic patients as a way in to find other families. The intervention results I showed indicate a need to tweak the program further, and we really need to have more training among healthcare providers for specific skills around dementia care, geriatric medicine, psychoeducation, social care, and counseling. There's a real lack of that in Singapore. I'm really running out of time, so I just want to end with this, well, maybe 2 more slides. When you talk about dementia care, when you talk about apps, recently I had a conversation about apps to support caregivers. It's very, very difficult to do that generally. So let's focus on dementia care. There are actually at least 4 archetypes that we could identify from this study, and service providers in the audience probably know this already, but researchers need to focus in on this differentiation in order to develop more targeted programs. Archetype 1 is persons with dementia lacking cognitive engagement. Archetype 2 is those with significant behavioral problems. The third archetype is those with limited social support. And then there's the newly diagnosed archetype, and all of these require different interventions and services. These are the different archetypes and explanation behind them. And I'm going to be sharing my slides, so you'll get this. Now, the WHO Global Action Plan for Dementia has a lot of interesting components to it. And this is what I related back to you earlier. WHO has developed principles for dementia-friendly communities that countries are now grappling with, and their concept is to achieve social inclusion, challenge stigma, improve care and services, and increase awareness. And there's a source here for those of you that are interested. And this slide is to help you look at specific country examples where awareness has been focused on social and cultural engagement, human rights, capacity building, and physical environment. So for example, New Zealand, Australia, and Norway have been very good at developing wayfinding programs for persons with dementia. And then I think Japan is a good case to study. In 2015, they actually made a huge effort to train primary care doctors and to develop research studies, 10,000 people in a prospective dementia cohort study, and to develop dementia-friendly communities, 12 million dementia supporters with good knowledge and understanding of dementia. So working at these different levels can help countries to achieve better care for persons with dementia and their caregivers. So I'll end there, Amina, and let's take some questions.
Thanks, Angie. That was an amazing presentation. Really covered a bit of information on this very kind of challenging topic. But for me, the really kind of the point that was going through my head all the time was how the medical and the social, aspects of it are so overlapped. And, sometimes I think we, look at one or the other, but I think there are topics and maybe many others that really we have to approach it from both sides. So that's something to keep in mind. But I invite the audience to put any questions they have in the little chat box. But we did receive some from before. So we had, when people registered, we asked them to post some questions. So let's just start with some of those. And maybe the first one I'll do is, someone asked, how do caregivers assess their stress levels effectively and then realize they might be at risk of caregiver fatigue?
I think that is something that one needs to, be rather self-reflective. If you're having difficulty concentrating, if you're feeling anxious all the time, one big indicator is inability to sleep. And feeling a real lack of interest in activities. These sound similar to depression, but they are also related to high stress levels. I think if a caregiver starts feeling this way, also very impatient, the person should reach out and try to get some support before things get worse.
And I also saw that, the qualitative, although we didn't have time to read all of them, but the qualitative responses seemed a lot more intense, maybe if that's the word to use, or, kind of showed the burden more than the quantitative, and the quantitative, as you showed, the needs were not, the unmet needs were not that huge. But can you just kind of reflect on what that might, indicate? When you really ask people, I guess in the qualitative, you're kind of making it very personal, right? Rather than just picking some boxes.
I think one of the things that it highlighted to me is, often we take these scales that were developed, in Western countries where people are more vocal about what they don't have, and willing to talk to and tell someone what they don't have. And it may not work so well in Singapore, for example. We may need to take a different approach to collecting data, either adapting the scales to make them to resonate more with the local population, or to use qualitative research to understand what the unmet needs are. So I think that there's a lot of development that needs to go on there in terms of scale development and different ways to collect data around unmet needs.
Okay, so I guess there's still a lot of work for people like you to be doing. And then I'll go back to the questions that were sent in earlier. And there's a question asking if there are public programs on how to care for people with dementia and really kind of so that they can watch out for signs for themselves as well as their loved ones. So I guess here they're talking of public programs in Singapore, although if anyone, and even from the audience, if anyone knows of them regionally, please feel free to share.
In Singapore, the Agency for Integrated Care has silver pages where there are a list of different organizations that provide caregiver support programs. And the other place would be the Alzheimer's Disease Association, which has programs to support caregivers and provide information on the disease.
So I guess this is just on their website or something people would go
yes.
to?
Yeah,
okay.
Yeah.
So I hope that's helpful to whoever asked these questions. Then another question that was posted earlier is, maybe can you provide, few daily living matters or tips that family members can do to help dementia patients?
One of the things that the evaluation showed was the value of providing activities for the person with dementia to do during the day, and also the value of getting the person outside, at least once or twice a day. It made a big difference in their mood and ability to sleep at night. So I think those would be two areas to work on.
Yeah, and maybe those programs that you mentioned would also kind of be able to address that issue, right? Hopefully they would incorporate that in the kind of public programs on how to care for people with dementia. And another question from our pre-list of questions is, what are the realistic expectations and sustainable measures for early detection of dementia?
Yeah, I think realistically, the one way for it to detect early is to have general practitioners trained to notice the signs of dementia, and that way we can catch it before it presents at a more tertiary level. I mean, this is not easy to do because in some countries, and Singapore is one of them, people tend to doctor hop. And so a GP may not know a family or a person who may be becoming cognitively impaired that well. So he or she can't pick up the signs. But I think better training at the GP level, that first point of contact people have with the medical system would help significantly.
Yeah, so I guess this kind of really goes back to that the social and the medical, fields closely together. And so from your just kind of, experience of working it so long, how are, like, say, the Ministry of Health, and their guidelines aligned with anything that the Ministry of Social Services, kind of is also thinking about, how do they work together?
So for Singapore, it is organized such that the Ministry of Health and our Agency for Integrated Care work together. And the Agency for Integrated Care does take into account both the social and medical issues. So their perspective is not just medical, not just the person with dementia, but the family. So they do take into account the caregiver, the family dynamics, and that's the AIC actually is how we manage a lot of the long-term care issues for persons with dementia.
Okay. That's good. I saw someone, Rachel Cruz, raised your hand. Did you have a question? I'm not sure why. You want to type it or you want to unmute yourself and ask your question? Rachel? It's nice to try to get actual voices.
Hello. Hi, Amina. This is Prof Chan here. Can I ask a question?
Sure.
Hi, Angelique. Very nice to hear the very detailed insight into your study. Can I find out about the cost of running such a program? It looks very resource intensive. There are many professionals involved. Is there any preliminary cost analysis as to how much you will have to pay to have such intervention?
So our preliminary analysis showed that for 6 months, it was about $2,500 for the program. But I think the program does need to be tweaked. I think that in terms of the dementia care program assistant, I think they need to have 2 of those, for example, because the role that person played was critical in the success. Developing activities during the day and helping with communication within the family, that really seemed to help a lot. Yeah.
But also, I mean, when you look at cost, then you're also thinking about that's the cost of the program, but what's the cost of the alternative? What would have happened to this both the dyad, both for the caregiver stress and any implications of that, as well as for the person living with dementia. What would their medical expenses have been? So it's always so complicated, right? When you think of what are the costs to a society as a whole.
Exactly. No, you're exactly right, Amina. And we didn't collect information on medical visits, hospitalizations in that 6-month period. So we couldn't do that analysis. We could just compare we could just look at the cost of the service. And then we're going to, in future analysis, we're going to be comparing that against cost of institutionalization.
Right. And then Cindy Fu asked, can we use mid-year career skills future credit to pay for the course? You mean for the intervention course, I guess? I'm not sure because I'm not an expert on skills. I don't know if Angie, you know the answer to this.
If it's a course for caregiver support program, if there is a charge, you might be able to. I'm actually not sure, but normally the ADA does not charge for their courses.
Oh, so you can just kind of sign up and go to it. Oh, that's great. Yeah.
Yeah. Yeah.
And then another question, is there any future plans or policy for aging-friendly community?
Yes, there are actually. OnePo is one of the communities that the MOH would like to make a dementia-friendly community. And so, and Ishun is another one. So the idea there has been to educate shopkeepers, police, people in the community about dementia, and then make people more aware. So the public education part of it.
Right, okay. And another question that has come in, there were a number of families who declined the intervention, and what were the reasons?
So a lot of families declining the intervention, they were often newly diagnosed cases. So if you can imagine, I mean, we were slightly concerned about this, going out, doing a survey and then saying to someone, you've actually scored badly and we think you need help. Some of the families didn't react very well to that. They said, we're fine. We don't need your help and we don't want to be part of this intervention. So that's why they declined.
Yeah, I guess just grappling with that diagnosis is an easy
Yeah.
task.
Yeah.
And actually that brings to mind a question that I have. I don't know whether you would know that offhand, but yes, what's the kind of trajectory, I guess, for people coming in with some, I mean, why would someone come in to get this screening, I guess, and, how is it delivered? How is it, received? Do you have a sense of, how that takes place?
So when when the surveyors go out and the person scores low, they have some form of cognitive impairment, the surveyors are not qualified to make any diagnosis. All they can say is, there seems to be, having some issues with your memory. Do you want to see a physician about this? And we also have this program. If a person says yes, then they go to the clinic in OnePo, the Sao Foundation Clinic, and a MD will actually evaluate them for dementia. And if they have dementia, then they are asked if they want to be in the program again. And if they do, they're taken. And if they don't, then they don't. So yeah, so that's how it was done.
Yeah. So there's a lot of kind of learning for that family to go through, I guess.
Yeah, that's why we have to be very careful, about that. There was a lot of thought into, there's a whole script that the surveyors follow if they see that the score is below 8 in terms of next step. Yeah.
Right, okay. Then a question again coming in from the audience is, what can an older person and their family members do to make a difference over the life course? I guess to prevent dementia coming, or to at least delay it. I'm assuming that's what the question is, to make a difference. Yes, they say yes.
Okay, one of the things that is a lot of dementia in Asia is vascular dementia, which means that you can modify the risk factors, which include hypertension, diabetes. And in fact, in the US, in the last 30 years, there has been a slow decline in the prevalence of dementia. And the researchers think it's because we've developed medications to manage hypertension and diabetes. And these are the risk factors for vascular dementia. So if you can, again, it goes back to lifestyle and diet, exercise. If you can be more, if you can, manage that better, then you will decrease your risks of developing dementia at older ages.
Okay. So, well, actually, that we don't have any more questions. We're out of time, and we end on a positive note. We end on the note that, yes, maybe there is something most of us, I think, in the audience haven't quite reached some of the ages that, some of this decline starts. So maybe we can all, think about it, make sure that we are on top of any of our medical conditions like hypertension and diabetes that, we might be at early stages. We can eat healthy, exercise, be positive, and hopefully be able to live that longer life with less disabilities.
Yes. Thank you so much, Amina.
Thank you for that wonderful presentation, Angie. That was great to have you here. Thank you all from the audience. Hope you kind of learned a lot from it. I certainly did. And we look forward to all of you joining our next month's presentation, which we'll let you know soon. And Angie, I'll connect with you separately. Thanks a lot.
Thank you. Bye.